Warm welcome. It's great having you with us again in this month, in this week actually. Welcome to our virtual grand rounds in radiation oncology. Very quick introduction as usual. We aim again in this week to provide you the latest evidence presented by the top speakers in our discipline, in our arena, and that in a very interactive format. This is kind of a special edition. We already had a virtual grand round lecture in the first week of the month, as you expected usually. But we have another exciting trial, which is kind of very much forward thinking. And so I took the opportunity of presenting you another virtual grand round right before Christmas. See it as a Christmas present in a virtual environment. At this point of time, and only for today and also for the last year, many thanks to our societies which are supporting our virtual grand round lecture, the Astro Society, the Swiss Radiation Oncology, and the German Society for Radiation Oncology. Thanks for endorsing our format and thanks for advertising and supporting it. If you have missed any of our lectures, please come to our homepage. You know that all our lectures are being recorded. You find many dear colleagues and important clinical trials being collected there. It's all available for free, so we do it without any support. So it's absolutely free and of any conflicts of interest. So come to our webpage and look at the recordings. In this week, I'm very happy to present and show you the LUNAR trial, a trial being presented by Amar Kishan. He's a professor and the vice chair for radiation oncology and urology at the University College in Los Angeles. And this is about oligometastatic prostate cancer, where we know that radiation in the field of external beam radiation has become kind of a standard of care. But we also know that many of our patients will develop disease progression because in many patients we're just seeing the tip of the iceberg. So the question is, how can we come up with a comprehensive strategy to treat what we can see on imaging, maybe PSMA PET imaging or whatever, and how we can address the microscopic disease. Many of our patients are treated with in addition of ADT, but some of our patients would reject it. So this is a very interesting concept of using internal and external radiation to target the microscopic and the microscopic disease. So Amar, many thanks for being with us this afternoon. Many thanks for presenting us the LUNAR trial. We're looking forward to your presentation, in particular looking forward to the discussion thereafter. The floor is yours.
Thank you so much for the kind invitation and an introduction. It's an honor to be here and present virtually to this group. Can you see my slides?
Perfect.
Okay. So here are my disclosures. Just so you're aware, this was an investigator-initiated trial. It was funded, however, by Lantheus, who I also do some consulting with. They did not have any involvement in analyzing the data or doing the write-up of the trial. So as was mentioned, metastasis-directed therapy has emerged as a tool for prolonging progression-free survival, or PFS, in men with oligometastatic prostate cancer, with stereotactic body radiotherapy, or SBRT, presenting itself as a highly effective modality with low treatment-associated toxicity. Highly sensitive prostate-specific membrane antigen, or PSMA PET-CT, has allowed the optimal identification of patients for metastasis-directed SBRT, but unfortunately, progression ultimately still occurs in a majority of patients, which underscores the existence of occult microscopic disease. In essence, perhaps what we're seeing on the PSMA PET is simply the tip of the iceberg. Most patients, unfortunately, are not cured with SBRT. Now, we know from advanced disease setting that PSMA-based radioligand therapy, which are basically agents that combine a radioisotope like lutetium-177 with a ligand to PSMA, have improved survival outcomes, both PFS and even OS, in men with advanced castration-resistant prostate cancer. They've been recently approved not only in end-stage castration-resistant prostate cancer, but now kind of chemo-naive castration-resistant prostate cancer. And there's even data that were presented at ESMO for the use of these agents in hormone-sensitive prostate cancer. But thus far, the observed impact of PSMA-based radioligand therapy has been on patients with bulky macroscopic disease. Our hypothesis that we investigated in the LUNAR trial was that adding PSMA-based radioligand therapy, here we used lutetium-177 PNT2002, which is kind of like PSMA-INT, it's the Lantheus compound, to metastasis-directed therapy in men with oligorecurrent prostate cancer would prolong PFS by acting specifically on the microscopic disease. In essence, we're using the radioligand to treat microscopic disease, using the SBRT to treat macroscopic disease. It was a fairly straightforward trial design. So we took men who had 1 to 5 lesions outside the prostate or prostate bed on PSMA PET-CT and did a 1-to-1 randomization. The control arm received SBRT to all sites. The experimental arm received 2 cycles of lutetium-177 PNT2002 at a dose of 6.8 gigabecquerel per cycle. The cycles were given 8 weeks apart. We then got an interval PSMA PET in 4 to 6 weeks after the final cycle, and then did SBRT to all sites of disease. Prior to randomization, we did stratify based on PSMA-based stage, so N1, M1A versus M1B. We also did include a stratification for M1C, but did not enroll any patients with M1C disease. And then we also stratified by lesion count on PSMA, 1 versus 2 to 3 versus 4 to 5. We had translational blood draws at baseline and 90 days post-SBRT in both arms. Now, very important, our primary outcome was progression-free survival, defined as the time from randomization until PSMA PET-CT-based progression, salvage hormone therapy, or death. So that's a composite endpoint. And I think it's unique in that we are including PSMA PET specifically based progression as our endpoint. Our rationale behind this is that, this is a pragmatic endpoint. At least in the United States, we're selecting patients for enrollment based on PSMA PET. And in the real world, if a patient receives metastasis-directed therapy and then the PSA starts to increase, logically, you would get another PSMA PET, and that's oftentimes going to influence management. Also, we felt that that was really a test of our hypothesis. If new disease is emerging on a PSMA PET, we're really testing whether we're acting on disease that was microscopic at the time of the enrollment PSMA PET. Now, PSMA PET-based progression was defined as either a new lesion on PSMA PET or local progression, which would be kind of like a 30% increase in SUV or a 20% increase in lesion diameter. We got the follow-up PSMA PET 1 year post-SBRT or at the time of a PSA-based trigger, and that was based on their enrollment PSA. So for men with low PSAs in enrollment, less than 0.5, it would be a 0.2 or greater increase in PSA. For those who had a PSA greater than or equal to 0.5, it would be a 50% increase in the post-nadir PSA. So this trial was open for a little over a year, September 2022 to November 2023. We screened 100 patients and ultimately enrolled 92. They were randomized. As maybe would be expected, there were some men that came specifically to get the experimental arm. So when they were randomized to the control arm, they dropped out. So although we had 47 assigned to SBRT alone, the actual analytical population was only the 42 patients who remained on that arm, whereas all the men who were randomized to the investigational arm remained on trial. So we have 42 patients in control arm, 45 patients in the experimental arm. I've highlighted some key kind of features there on the right from our baseline clinical feature table. You can see the PSA was pretty low, it was 1.2 and 1.1. So this is an early oligorecurrent setting. Prior exposure to metastasis-directed therapy was seen about 38% of patients in the control arm, 29% of patients in the experimental arm. And in terms of stage by conventional imaging, we did look at this as well. Most patients didn't get a bone scan, but they did have the CT component of the PET, which could be read independently. We found that the vast majority of these patients did have N0, M0 disease, but there was a small minority that had M1B disease. So 20% that had M1B disease on conventional imaging were enrolled in this trial as well. When we look at some of the refined points with regards to the PSMA PET, you can see that it's pretty equal as we'd expect because of stratification, but about 62% of patients had N1, M1A disease. The remainder had M1B disease. And in terms of lesion count, we see that about 42% of patients had 1 lesion, 42% patients had 2 to 3 lesions, and only a minority had kind of 4 to 5 lesions. And I will highlight that the SUV max is actually pretty low here. We're talking about 6.4 in the control arm, 4.9 in the experimental arm. So this is kind of different than some of this advanced disease trial population where patients had very bright, bulky lesions. So it's early oligorecurrent disease. So when we look at kind of the PSA-based response, you can see on the left there's kind of a waterfall plot, patient-specific, kind of the best PSA response that was seen. There is a better PSA response in patients that got the kind of combination treatment. But if we look overall, we can see that 71% of patients on the lutetium arm did have a decrease in PSA after 2 cycles, but 27% had an increase. So this wasn't necessarily a magic bullet to get these 2 cycles of lutetium. And in fact, because we got that interval PET, we could see that the impact on the macroscopic disease was not so robust. 7 patients, 16% had a kind of 30% or more reduction in target size. So, it was important to still have the SBRT here. The lesions did not go away with 2 cycles of the lutetium PNT 2002. That said, the overall PSA decline, if we look and follow after SBRT, was significantly better on the experimental arm. So it declined greater than or equal to 50% and 31% of patients on the SBRT arm, 52% of patients on the experimental arm. Of course, we want to look at our primary endpoint, progression-free survival. The median PFS did increase from 7.4 months to 17.6 months. This was highly statistically significant. The hazard ratio was 0.37. 98% of progression events, or 64 of the 65 progression events, were driven by new lesions. And that's very important, right? Because that tests really our hypothesis. The one exception was a patient on the experimental arm that had a rising PSA. Their PSA actually exceeded 10, but PSMA PET was negative. They elected to start hormone therapy. So really, again, the vast majority of these progression events were microscopic disease that was emerging new out-of-field failures. On a per lesion basis, the local control was very, very high. So only 2 of 91 lesions on the control arm, about 2%, had local progression, and none of the lesions on the experimental arm, had local progression. In terms of hormone therapy-free survival, which is a key secondary endpoint, that was substantially improved as well, increased from 14.1 months to 24.3 months. Again, 98% of patients who received salvage hormone therapy had new lesions on PSMA PET. The one exception was the patient I described on the experimental arm. And repeat metastasis-directed therapy without hormone therapy was delivered in about 1/4 of these patients. So, still an option to continue MDT. Obviously, whenever you intensify treatment, you want to think about toxicity. And we did look at various metrics of toxicity. There was no significant increase in severe toxicity with the use of radioligand therapy here. You can look at, lymphopenia, the p-value is 0.08, and maybe if you looked at specifically, grade 1, grade 2 is a little bit greater numerically, but we didn't see the significant difference in grade 3 toxicities. And, one of the concerns, dry mouth, dry eyes, we didn't see that either. I want to highlight here that this is important because a lot of, people would have hypothesized that we would see a reverse tumor sink effect in this trial, meaning since the burden of disease is so low, it could be that you're overdosing some of the organs at risk. That does not appear to be the case based off of these toxicity data. We also have some dosimetry data that is in submission that will look at that in more detail. Now, we did have a number of correlative analyses, as I mentioned. We looked at the productive rearrangements in the T cell receptor 90 days after SBRT. There have been some work by other groups that have shown that this is prognostic, in that more rearrangements is a positive prognostic feature. So when we looked at this in kind of like a trial arm specific way, so looking separately at the patients in the combination therapy and in the control arm, we see a trend, but didn't see a significant difference in the TCR rearrangements between those who progressed and those who didn't. But when we combine the arms together to improve the power, and we look at this, we see that, in fact, for every unit increase in productive rearrangements, in the log of productive rearrangements at 90 days, there's a significant reduction in the hazard of progression. You can see the hazard ratio there is 0.46, highly statistically significant. We also have an interest in our research group at germline biomarkers of progression. So we looked at this as well. Specifically, our group is interested in kind of a microRNA binding element, single nucleotide polymorphisms, and how that could account for differential response to therapy, both for toxicity and for outcome. And we found a signature based on 25 of these single nucleotide polymorphisms that did stratify patients within each arm of the trial for those at higher risk versus lower risk of progression. And one way of looking at that is something called a time ratio. So on the left here, these are patients in the combination therapy arm. You can see that there's a significantly delayed time to progression in patients who are predicted to have a low risk of progression based on this germline signature. In the control arm, that's similar magnitude, not quite statistically significant, but close, maybe issues of power there. And I will highlight that this maybe logically makes sense because many of the genes involved here are immune response and DNA repair genes, which we would think could be, relevant in this type of a phenomenon. So in terms of conclusions and future directions, adding 2 cycles of lutetium PNT 2002 to SBRT significantly improved PFS in men with oligorecurrent prostate cancer, presumably by action against a cold metastatic disease, without an increase in severe toxicity. The PFS was based on PSMA PET, so that is something to think about. It might not have the same prognostic impact as conventional imaging progression, but certainly is highly pragmatic. Yeah, this was what's going to happen in the real world. We did have some interesting correlative analyses results. TCR productive rearrangements were prognostic, and there was this germline biomarker that identified patients at higher risk of progression or not. But ultimately, right, 64% of patients on the experimental arm still had progression. So there's, must be ways of improving that as well. There wasn't that clear plateau in the survival curves necessarily. So this can be refined, whether that's with a different type of radioligand, a higher dose, a higher number of cycles, playing with the sequencing, et cetera. These are open questions. And before hopping into questions, I just want to thank the whole broad team of authors that was responsible here. Specifically, I want to thank Jeremy Calais, who is my co-PI in nuclear medicine as well. Thank you very much.
Congratulations, many thanks for giving us an overview of the LUNAR trial, and congratulations to this fantastic achievement. There's opportunity to ask questions, so please use the Q&A functionality in Zoom to ask any question. 2 have already been asked, and then 1 you mentioned already. I mean, still the majority of patients did develop disease progression, so the question is, how can it be further improved? You mentioned you could obviously give some more doses of the radionuclide therapy that might have the consequence of increased toxicity. You mentioned another radioligand with different characteristics. So Stefan, Biden has asked the question, how about radionuclides with a higher linear energy transfer and a higher dose deposition, such as terbium-161 or alpha emitters? So is that something you would consider in a follow-up trial, or?
Yeah. So Stefan has read our minds here. So I'm very pleased to share for the first time publicly that we just activated a trial yesterday. It is a Novartis-sponsored IIT, but it's our follow-up to the LUNAR trial, which is basically a 1-to-1 randomized trial. One arm group will get 2 cycles of Pluvicto. So it's a Novartis trial, so the drug is slightly different, but that is the experimental arm on LUNAR. The other group will get 1 cycle of actinium PSMA 617. And the idea is that maybe the actinium agent will be more effective against microscopic disease. So we're going to be testing this in a 1-to-1 randomized trial, phase 2 trial.
Thanks for the question. So any new question, please use the Q&A. Another question, what was the rationale for 2 cycles? Obviously, has there been any rationale before? How can you explain?
Yeah, that's a great question. So, we didn't want to go to a higher number of cycles because this is very early disease, and we want to think carefully about the toxicity proposition here. This was a proof of concept trial. We didn't know that it would work, so we didn't want to go, all the way with a higher number of cycles. At the same time, we didn't think 1 cycle would be enough. I don't know that there's so much precedence for using 1 cycle. Most of the data have used a little more cycles than that. So we went with 2 cycles, but obviously that was a little bit of a guess. And similarly, I'm sure a question could be about the sequencing as well. And that was also a little bit of a guess, whether, we should do this as a sandwich, whether we should do adjuvant, whether we should do neoadjuvant. The reason we did neoadjuvant is because we wanted to investigate what would be the action of this radioligand therapy in this kind of low disease burden population. And we had that interval PET, right? So we gave the 2 cycles, we had an interval PET. We could really see, was this eradicating the disease already, right? And it wasn't. So the SBRT was still required here. A corollary, though, may be that if there is something to this immune phenomenon that stimulating this immune response from the SBRT is helpful, maybe it is better to front load the radioligand, because there was some lymphopenia, and there's a possibility, as we saw in the Ravens trial, that if you give adjuvant radioligand therapy that has hematologic toxicity, you might blunt a favorable immune response, and you could even reverse the signal.
One question about the sequence, and I fully understand the rationale in the clinical trial environment. If I would do a clinical or a consultation of a patient, I would consider a different sequencing. I would start with an SBRT approach, in particular in a patient having low tumor burden, monitor the PSA response, and then maybe consider in an adjuvant or call it a maintenance setting in patients which do not have a deep response. Is that a strategy you would also pursue? Kind of monitoring the response to SBRT only because we know, and looking at the STORM trial, there's a relevant proportion of patients where we're not only seeing the tip of the iceberg, which can be stabilized for a longer period of time, and only in the subpopulation could have a true benefit of adding radionuclide or ADT, whatever.
Yeah, it's certainly a great point. Maybe an adaptive kind of approach in the adjuvant setting could be used with this as consolidation therapy. Um, we were a little surprised with the high event rate in the control arm. And it certainly is a more rapid time to progress than seen in other trials. That could be because, we are using the PSMA PET at fixed intervals, right? Every patient got it 1 year after therapy or at a very low PSA trigger because we thought that mimicked the real world practice. So I wonder in some of the older oligomet trials, obviously they're great, but they did use either conventional imaging or they had a higher bar to do the functional imaging. The progression rates may be higher than we think. So that would argue, yes, obviously, maybe if we have better biomarkers to select who needs this, I 100% agree with that. But there could be, the STORM trial PFS in the SBRT arm, which also did include 6 months of ADT. So there's also that impact of recovery of testosterone, et cetera. That may be higher than what we would see in a PSMA followed group of patients.
Another question by Christian Frankhauser, urologist from Winterthur, about the long-term toxicity. The question is, what do you add to local treatment? You can say in ADT, 6 months it was in STORM. Also, Radiosa was adding 6 months of ADT. So, what could you comment on the long-term toxicity profile of having a short-term ADT as compared to a radionuclide therapy?
Great question. I think we're going to need longer term follow-up for that, and probably, honestly, a bigger trial to be able to pick up some of these potential safety questions. It's a great point. I would say from the patient standpoint, many men do not want to go on ADT, right? Understandably, because of the quality of life impact. With short-term ADT, that is reversible. That's true. But it's still something that they have to experience and deal with. And that's one of the reasons that this trial accrued very well. As you can see, it was a single center IIT, but we got 100 patients in a little over a year because nobody wanted to go on ADT, right? And it seemed like this was a good option for them. But to answer the long-term toxicity question and really to compare with ADT, we would need a much larger trial with longer follow-up.
One question we already had discussed before we were starting the webinar is what would be the duration of effect of a radionuclide therapy? If you look at the metastatic data, you have the impression you have a good response, but the duration of response is not super long. So, do we have any good preclinical data, animal data, that we actually could increase cure rates, so increase the plateau of eradication of microscopic disease?
It's an excellent question. I don't think we have those data. There are groups at my institution that are working on that. And I think with these data, we'll try to study the oligomet space or the early disease space a little bit more. Most of the work so far has been in advanced disease. So this is a little, this is a little bit of a different scenario. I think it is fairly novel that it worked against microscopic disease. That was kind of the hypothesis that appears to be correct. We would hypothesize, like one of the questions asked earlier, and our next trial would look at that maybe a better radioligand could achieve the plateau that we're looking for, like an alpha emitter, but maybe also a higher dose of a beta emitter.
Maybe one question I haven't seen it in the paper and also not in the presentation. Did you look at the location of recurrence? So could you say that, for example, for microscopic disease in the lymph node, it works better as compared to the bone? So do you have any kind of conclusion from the recurrence pattern on where it might work better or worse?
Yeah, we looked for strata-specific effects because we did have the stratification. So there was no significant interaction of like a differential effect in the kind of N1, M1A versus the M1B strata. Granted, these are smaller subgroups, so you can't rule out a potential difference, but there didn't appear to be a difference based on the location of the disease.
Apologies. I was not asking about if there was a prognostic effect of the initial kind of tumor burden. The question is, where was the location of recurrence?
Oh, I
Uh,
see.
so was there a
After
difference
our
in
therapy.
recurrence
Yep.
pattern in numbers? I got
Yep.
it, but in location and
Yep.
between the experimental and the control arm.
Yeah, we have not looked at that. That's something we plan on looking at. Another thing we want to look at is whether there is different definitions of polymetastatic recurrence. That might be like a harder endpoint than like a single lesion on PSMA PET. People can argue about the prognostic implication of that, but multiple polymetastatic progression, I think people would put more weight on that endpoint. So those are things we're looking at. Apologize for misunderstanding the question.
No worries, no worries. Then one question about the patients which have been enrolled. The majority of patients had just one single metastasis, as in most oligometastatic trials, and I understood the majority, I think it was 60%, were having nodal disease and M1A. But how many patients were having only nodal disease in the pelvis? So M0,
M0N1 was about 25%, I believe.
25%. And there was no use of elective nodal irradiation, I guess. It was only
Correct.
kind of focal radiation.
Correct. Yeah,
SBRT.
this was yeah.
Okay. What would be if you could have, let's say it's close to Christmas, you're winning the lottery, you have 10 million. So you can design a randomized phase 3 trial in oligometastatic prostate cancer. How would you design it?
That's a great question. Well, I would want to see if we can replicate these results in a large phase 3 trial. Um, I don't know that ADT combination is the right uh, combination, but I think a three-arm trial that has SBRT alone, lutetium plus SBRT, and then ADT plus SBRT with an endpoint of eugonadal polymetastatic progression-free survival would be an important trial. Obviously, adding ADT, the reason I specify eugonadal, if you add ADT, you're going to improve PFS, guaranteed, because of the suppression of disease and then the testosterone recovery. So I think the fair comparison would be to look at eugonadal progression-free survival. And maybe that harder endpoint of multiple disease on PET, so polymetastatic progression.
So you mentioned organoidal progression-free survival, organoidal polymetastatic disease progression. None of these endpoints are kind of truly hard endpoints being
Mhm.
accepted in the oncological arena. Would you feel
Yeah.
comfortable setting up a phase 3 trial and with that as a primary endpoint, or would
Yeah.
that be a secondary endpoint and still kind of use PFS despite all the limitations, or maybe even overall survival as a primary endpoint?
Yeah. I think I do think actually we need new endpoints in this space because pragmatically, so yeah, yes, you're correct that, many people would say the hard endpoint is conventional imaging based metastasis-free survival, which has been shown to be a surrogate for overall survival. I think if you designed a trial with that, it would have substantial issues with censoring because again, in the real world, if a patient has a PSA that's rising, they get a PSMA PET, it identifies metastasis, that's going to be acted upon, right? There are very few people they would pull off the trial. They'd get a non-standard, treatment at that time. Again, because this is enrolling those patients. So it'd be a little bit logically inconsistent if we were saying that having PSMA-based disease is enough to enroll on this trial, but then having that as an endpoint is not enough to warrant a change. So I would hope that as a field, we will be able to generate enough data on the importance of a PSMA-based endpoint that could be a hard endpoint that's accepted within the field. OS, I think, is impractical because thankfully these men live a long time, right? This is early prostate cancer. There's so many downstream treatments that are successful. You're never going to show an OS difference.
So many thanks for the comment about alternative endpoints. We are just kind of about to wrap up a project within the EORTC and ESTO where we ask what are appropriate alternative endpoints in oligometastatic patients. Overall survival is impractical for many of these patients, having a very long overall survival expectancy. And also there are some aspects which might be more relevant from a patient perspective: quality of life, preservation of sexual function, deferral of systemic therapy, maybe also kind of cost efficiency endpoints. So that is a work which is ongoing. I'm looking at the time. We have 30 minutes past 5. So, Amar, many thanks. Huge congratulations for your work. Keeping fingers crossed you win this 10 million lottery to do the follow-up trial. Fantastic having you in our virtual ground lecture. Everyone else who has been joining today, huge thanks for staying with us today, shortly before Christmas, further deferring your Christmas shopping. Wishing you a Merry Christmas time. Hope to see you next year again for our virtual grand round. So stay tuned for the next meeting in January. Good to see you. Good holiday time to everyone. Bye,
Thank you so
everyone.
much. Bye.